Good day, good day, good day. Nazim's new song, a small group today, and I'm not surprised. It reflects the fact that we are at a very interesting stage of the COVID pandemic, and also at a very interesting stage of the year, towards the end of August, August 26th, when, quite honestly, there tend to be a lot of people away on holiday. But I see that it's a very, very excellent participation. And in a time-honoured way, I'd like to invite Catherine Deland to initiate our work today. And I'd just also like to say that Mihika Acharya, I think, is on as well, but I'm not sure. She'll explain if she is here why I was unsure, and we'd give her a chance to say a word in the middle. My remarks will be short, and just, Catherine, I am planning this time to reflect a bit on what we're finding through the work of the Global Crisis Response Group of the UN Secretary General, because more and more we're seeing that the current global crisis, what some people call the cost of living crisis, is very much influenced by how COVID has affected societies everywhere. And there's still a lot more to be worked through on that. Here we go, Catherine, please.
Thanks so much, David. I think the only matter of substance that I would want to mention is as much as COVID has influenced everything over the last couple of years, it's really important to remember we still have thousands of deaths and hundreds of thousands of cases every week. So it is an ongoing problem. And I know you're going to emphasize that. But just as a welcome, hi, everybody. Happy Friday. I hope the morning, afternoon, or evening, wherever you are, is being good to you. And I do want to mention, you will have already seen the pop-up on your screen. This is being recorded, and we plan to post it onto the 4SD website. Should you make any comments that you do not want to be in the public domain, please let Mihika or I know. I'll make sure our email addresses are in the chat so you can do that. And in the meantime, David, I'm really looking forward to hearing your thoughts. Thanks so much, everybody.
Thank you very much indeed. For those of you who have not been here at one of these events, we are doing them every fortnight. They last an hour. I am offering an open online briefing in my capacity as Special Envoy of the Director General of the World Health Organization for COVID-19 response. It's an open event, and what will happen is that after I have offered you my perspectives for slightly under half an hour, I'll then stop and invite reactions from participants. Because we meet quite regularly, and we've had well over 100 of these meetings since we started, there are people here who come on quite regularly. And I shall be inviting Claire Rayner, who is for me, a very persuasive occupational physician who's working on long COVID in a variety of ways. I shall invite Claire to make some comments. I shall invite our colleague Gawaha Atif, if she would like to speak. I will also invite Gregory Hartle, who comes from the World Health Organization and is in their communications team, to offer his points of view. And there are others on as well who I would like to call on, but I won't embarrass them by naming them right now. And if you're going to be in a position to speak, do raise your hand using the raise hand function, or do put a message in the chat and we will pick it up. I'd like to greet my sister, Annie Appleyard. I'm so pleased to see that you're here. This is important. As Catherine said, this COVID-19 pandemic continues. There are still several thousand deaths per week. A virus, in my view, is dangerous because it's causing these deaths or associated with these deaths. The virus, to me, is dangerous also because of the very large number of people with long-lasting symptomatology after their initial infection, or with long-term sequelae after their COVID infection associated with higher risks of morbidity and even mortality, particularly in their cardiovascular systems. So we take the view in the World Health Organization that it's not appropriate just simply to be saying that living with COVID means disregarding the virus. We say living with COVID means being highly respectful of this mutating virus, and it means taking the necessary action to reduce the risks to people and to society. And that means that we do encourage all governments to establish and be transparent about their national strategies. And we would also like to encourage them to be very clear about the public health and social measures that can be used to reduce transmission, and about the policies that should be used for vaccination, particularly to protect those who are most at risk. So what do we know about the epidemiology? Well, we know that the virus, even in its less severe forms, like the different subvariants that are in the Omicron family, this virus really does have remarkably different effects depending on people's ages. If you're in your 70s, like me, your risk of developing severe illness and of dying when you get infected by this virus is many times greater than if you're in your teens or in your 20s, hundreds of times greater. And so we need right from the start to recognize that this is a virus that preferentially hurts older people. It also preferentially hurts people who've got diabetes, people who've got cardiovascular disease, people who are immunocompromised, and people who have a very high level of exposure, such as, for example, health workers who are doing ear, nose, and throat and who are having to deal with people who are secreting a lot of virus, or people who are working in intensive care units and the like. And we believe that in 2.5 years, we have learned about this differential impact, and our strategists should take account of it. We should remember it's not a condition that affects everybody in the same way. We notice also that the virus, constantly evolving, is emerging with new variants and subvariants. And these variants actually over time appear to be more transmissible than their predecessors, quite simply because in biological terms, a new variant is more likely to become the dominant variant if it's more transmissible. Actually, in the same way, a new variant is more likely to become the dominant variant if it doesn't kill people, because viruses actually have a huge advantage if they keep their hosts alive, because that means they can multiply and propagate and be quite happy, whereas if they kill their hosts, then that's pretty bad news. And so those of us who've been watching this pandemic evolve have been expecting over time, but it's bumpy, it's not straightforward, that the new variants that emerge and that become dominant, that's the important expression, are more likely to be less lethal than their predecessors and more transmissible than their predecessors. That's why we're not surprised to see that these Omicron subvariants BA4 and BA5 are really super transmissible, especially in confined spaces. It seems that you can pick them up with only relatively short amounts of time in contact with people. We're also really conscious that as the virus evolves, it develops the ability to escape from the protection offered by vaccines. It's not a complete escape. I must stress to you that these vaccines that have been made available really in well record time seem to be remarkably good at protecting people from getting severe illness and from death. But they don't stop you from getting infected. And that means that we all know people who are getting COVID again and again and again. Because not only are the new variants capable of getting around the protection from the vaccines, they're also capable of getting around the protection from previous infection. And indeed, the protection from previous infection seems to wear off quite quickly in some people. It's not everybody, and that's the problem, that experiences with COVID are hugely varied. And each one of us who's had COVID have got a different story to tell. One or two common features, like you have the most awful dreams and it tires you out like anything, but they're very different. And that's why it's so difficult communicating about COVID. It's so difficult establishing policies. And that's why we've got these really massive battles going on with people accusing those of us who are working on COVID of all sorts of bad things. I have 3 words that I use all the time when I'm trying to help people on this. Prevent transmission, I say. Protect people who are most at risk, the older ones and the people with other diseases. And prepare for surges, because this virus tends to come surging up about every 4 months, sometimes with massive surges because of a change in the structure of the virus. And so when you've got a surge coming, that's when you should really be encouraging everybody to be on their alert, to be preventing transmission and making sure they're protected. The world in the northern hemisphere, where I'm broadcasting from in Geneva, we're expecting that there will be some surges coming up in the winter months, especially when people are gathered close together, huddled perhaps because it's cold. And because of that, we're suggesting that nobody throws away their masks, instead that we keep them with us. And when we pick up that the numbers of cases in our area are on the increase, then we really should go back to wearing our masks, especially if we're trying to protect someone else at home, older person who's got other illnesses, or if we ourselves are worried about our own health, or if we think we might have the virus and we want to stop others from getting it, wear that mask. And I'm very gratified to see here in Switzerland, but also in other parts of Europe, that the wearing of masks, particularly on crowded public transport, is picking up again. A sign, I think, that the public at large realize that the virus has no way gone away and that masking is a sensible practice. The other thing is to keep your distance from other people, makes a huge difference. Second thing we're saying is protect yourself. And how do you do that? You get vaccinated. And what should you be doing now, especially if you're in the 70s, is you should be having your second booster, your 4th shot. Get it. If you don't, want to because you had bad effects from perhaps previous vaccination. Okay, think hard about it. I must say that I have not had bad effects from my vaccinations. I was very pleased to have my 4th vaccination recently. It was an mRNA vaccine. And I really do encourage people to do that. Now, we are in a stage where the response is heavily politicized. Anybody who encourages efforts to prevent transmission, protect people, and prepare for surges can get quite heavily attacked. There is some rather odd stuff in the UK press with statements being made by the candidates for the new leader of the Conservative Party, basically deciding that it's okay to take a pockshot at epidemiologists and others who've been trying to be helpful. But the fact is, everybody, this is still a relatively new virus. Its behavior is still not fully understood. There are still not clear, agreed practices for getting on top of it. And I encourage everybody to follow what Tedros, the Director General of the World Health Organization, is saying quite closely, and to be doing what they can to reflect best public health practice in dealing with this, because the virus is still here. In my view, the virus is dangerous. So there's been more than 1 million people dying associated with COVID-19 this year. 1 million. I mean, that's a lot. And cases are rising again. And in some places, it's particularly complex. I've been working with the team in a small country in the Pacific, land-wise, called the Marshall Islands. They cover a huge sea area. And the arrival of COVID in the Marshall Islands in the last 2 weeks has caused major, major difficulty and will upset the viability of the country. It's led to restrictions on movement, got all sorts of people working for the local airline out with COVID. And it just is a reminder that not only does this virus cause some people to die, a lot of people to get long COVID, but it also eats into the fabric of society and affects people's ability to get an income and be employed, and creates a lot of uncertainty in daily life. We've always said, those of us working on communicable diseases have always said that the time when a disease outbreak is coming down, you're coming down the downward slope, as we say, of the epidemic curve, is a bumpy road. It's not straightforward. People are fed up with being asked to be careful. But I do want to stress that I think it's our collective job to remind people that this isn't finished, it's still unpleasant, that the new variants are highly transmissible. We can't be sure of what some of them are going to be like, so we need to be careful. Long COVID is still not fully understood. It's a multitude of different conditions. A lot is written about it. Many people are affected, and it's therefore not a laughing matter, not a matter to be trivialized. I thought I might just spend a moment on long COVID. I think it can affect people differently. And my own view is that one of the ways in which the virus has an effect on humanity is by attacking the cells that line blood vessels, what are called the endothelial cells. And if those endothelial cells get damaged, there's a much greater likelihood that there will be little clots that form in the bloodstream. what are called microclots. That's what tends to happen when cell walls are damaged, when the lining of little arteries is damaged. And we've discussed in these sessions before how this vascular damage and the microclots could well explain some of the tiredness features of long COVID, breathlessness features of long COVID, heart impacts of long COVID, and more. There may well be other features around long COVID, particularly damage to people's mental well-being, that need to be given attention. They may be due to microclots, or they may have other causes. But there's absolutely no doubt that long COVID is associated in many people with exhaustion, with depression, with real damage to their cognitive ability. And I'm really pleased that Dr. Claire Rayner is here. She sent us an article on long COVID and the return to work, in which she says, while many people with long COVID return to work and stay in and thrive at work, some do require appropriate support and work adjustments if they're going to do this. But there's a significant gap in the confidence and capability of different organizations to provide the right support. Organizations should work with people who've got long COVID so that together they can come to feasible solutions. And that might include providing psychological and physical support structures to make it possible. In Australia, a government analysis seen by Agence France Presse on Friday has showed that long COVID has already cost the Australian economy 3 million working days this year. And long COVID is significantly worsening the country's acute labour shortages. But, you know, COVID and responses to it have had a huge effect on societies everywhere, with hundreds of millions of children not being able to enjoy full schooling in the last 2.5 years, with hundreds of millions of people not being able to be in full employment. We've seen breakages in tourism, in food systems, in governance, in leisure, and of course, in most large businesses with big supply chains. And those of us who are working on the evolving global crisis right now, which I'm doing with the United Nations, are gradually realizing that many of the aspects of the current crisis do seem to have been exacerbated by the whole COVID process, by climate change, by wars, obviously including the Ukraine war, and that taken together, they're a pretty toxic set of shocks for societies everywhere, and they are having really damaging impact on the economies of poor countries, to the point where perhaps there's as many as 40 countries that are in real difficulty with their exposure on debt right now. And if we look more broadly, there are food crises and other aspects of the cost of living crisis really biting in perhaps as many as 60 or 70 countries, and really affecting the lives and livelihoods of nearly 1 billion people. So we are in the midst of a cost of living crisis, and myself and others believe that this has really been very much influenced by COVID and responses to it, as well as some of the other shocks that are going on at the moment. So public health and public health physicians are in quite a tight spot at the moment, because in public health, we are used to advising governments on measures that can be taken to reduce risk and reduce risk for the wider population. We tend to argue that everybody's life has the same value, and so we are very much pro-equity and pro identifying those who are most at risk and preferentially supporting them. And yet, it does seem that in some countries, the political process finds it relatively easy to forget history and to sideline some of those who are most susceptible. And we saw that with regard to COVID vaccine, with people in poor countries finding it much harder to access vaccine early on. We saw it in some wealthy nations with people who belong to minority groups and who are poorer, finding it much harder to access treatment and to be protected when they were at risk. And so the public health community, because it has a natural focus on equity, is facing a bit of an uphill battle when it comes to dealing with people who would turn around to us and say, look, for young people and most of the people in society, this virus causes relatively mild problems. We are going to disregard your advice. And so the current debates, particularly in Britain, about public health advice are a little bit disturbing. I was introduced on Irish radio this last week to a new word to describe post-pandemic anger. It's called panger, P-A-N-G-E-R. It's quite difficult to be offering public health advice when one is immediately confronted by manifestations of this anger and anxiety. But I think that part of the revision to our ways of working in public health as a result of COVID will have to include ways to take account of this anger and frustration, which is often put in terms like, why should we listen to the advice of unelected, self-appointed health experts? What we need to do is to leave all the decisions to elected representatives. And so what those of us who work in this area have to do is to make sure that our communications are as clear and humble and honest and hopeful and human as we can make them, so that we will at least be seen as authentic and given some space to offer our advice. And in turn, I shall respond, of course, by saying, when asked my opinion, I will not see it as my role to say people should do A, B, C, D, E, or we should do A, B, C, D, E. I'd rather say my view is, or in my experience that, or when I had my COVID, the other, trying to make clear, if I'm asked my advice, that I'm talking very much from my own experience, and that I do not see myself as having any authority to tell others what they should do. Those are my opening remarks. I hope that they are of some help, and I'm super grateful to you all for being here. As there are some I don't know, Chris at Reconciliation Media, I see you've turned off your camera. I think I recognize you. David Holland, how do you do? Thank you for joining. I hope you find it helpful. And I want very much now to see whether or not there are people who would like to make some remarks. Catherine, please, if you would like to point me in anybody's direction, please do so. And I'm looking for Claire Rayner because and Gregory Hartle. I'd like to come quickly to you, but Catherine, if you'd like,
Certainly.
anybody you like me to encourage me to talk to.
Well, no, you mentioned at the beginning Claire, Gallagher, and Gregory. So those are on the list, definitely. And Marianne has put some really interesting comments into the chat about the impact of COVID on women and the disproportionate way that they are being not to use the word impact twice, but impacted. So
Okay, cool.
I throw it back to you.
Thank you very much indeed. So this is the order. Claire, please, first, then Gregory, second, then Gower, then Mary Ann, and then we will stop and see whether any hands go up or anything else. And meanwhile, I'm just checking to see who else has joined. Welcome to Florence Egal. Welcome to Claire Taylor. If either of you would like to speak, that'd be nice. But first to Claire Rayner.
Hi, everyone. It's really good to be back again. It was a nice surprise to get the email. And thanks for those words, because I think they are really helpful. What you said about anger, I have noticed this collective anger, and I kind of keep thinking, oh, so-and-so's got funny responses here and there. So I think there is a lot of anger coming out, and I think your words are really useful about how to communicate with that. As regards long COVID, I can but agree with what you've said. Yesterday, somebody asked me to accompany them into a meeting with one of the chief nursing officers in the UK. And I was really quite shocked by the rhetoric. It was because we just wanted to talk about protecting healthcare workers. And they said, no, it's all right. We know all about risk assessment, but the pandemic's over and we need to move back to normality. So I was quite surprised at that. So I agree, we still have some real issues from the highest level. And I want to see people protected with simple public health messages. My concern, I suppose I'll speak for today. I know people who have been infected in the first wave and who've really got very severe ongoing problems 2.5 years later. And they haven't been able to access health services. So I think health services in general have broken down here in the UK, very much so. So there are people that have had, today, after 2.5 years, have discovered significant hearing loss. Since the start of the virus, and they could not get these things investigated. So people have had what I would call red flag problems, health problems earlier on, vision loss, spinal cord symptoms, and unilateral one-sided hearing loss. And a year to 2.5 years on, the damage is being found, but they were turned away from health services. And my colleague Claire Taylor will perhaps just give a little bit more information on that. So yeah, my concern now is obviously about helping people to stay in work. The trains where I live from Manchester to London, which is a 2-hour train ride, have been reduced from 3 an hour to 1 an hour. And I was asking behind the scenes, why is that? And they said, because we literally don't have enough staff. And that's across other industries as well. I think health services is now the big problem. There are people, so those are my main points that I wanted to say.
Thank you very much indeed. We will come to Dr. Claire. Thank you for joining. Really, really lovely. And Claire Rayner, it's the conversation with you is ongoing, and you have been with us so many months, and you have become a really, really important spokesperson for the long COVID community. I just on behalf of so many hundreds of thousands of people, I really want to thank you for what you do. It must be lonely sometimes, and it's so important. So thank you.
Thank you so much. I think the working with other people that want to try and help is wonderful.
Great.
Thank you.
Thank you. I've put Gregory Gower, Marianne, Claire Taylor, and then Florence Egal. So let's go to Gregory, please.
David, thank you very much, and hello to everyone there. First of all, I am always so in admiration of how well David speaks and how succinctly he has put all the challenges that face us going forward to continue to try to maintain any times any sort of a communications profile for a public health perspective and public health recommendations and response on this disease. We have seen, I think, more and more and more. I think fascinating what you say, David, about the word panga, that this thing is a manifestation of, I think, something we felt for a long time, and it really limits our ability to be heard. I know that at WHO, the DG still talks every week during his press conference about COVID, and it was a sign of how little attention is currently being paid to it, that at yesterday's press conference, when after the DG announced that we had crossed this terrible threshold of 1 million deaths this year from COVID, that there was not a single question from journalists on the subject. Journalists just aren't interested in COVID any longer. And yet it is so true, everything that David said about the fact that it's very much still with us. It will likely, we'll see a recrudescence in the winter months, and that we need to maintain, especially going forward in the winter months. Also, I mean, because obviously of it being colder, one having to be inside, there being less distance between people, etc., that we need to ensure that people do respect or follow as much as we can humanly make possible social distancing and masking measures. But we are fighting an uphill battle, and you know, we have people crying out from our partners for more messages, but who actually reads these is difficult, because we don't actually have that much new to say. And I think, as we all know, news is something new. And if we could somehow encapsulate evidence about long COVID, or evidence about what David was talking about the greater transmissibility and less, let's say, severity of the new variants, if that can somehow be quantified, that might give us a chance to make some sort of inroads. I wanted to talk briefly on another topic too, which is, you, I'm sure, are all well aware. Dr. Tedros launched a process which is a member state driven process. And we want to make sure that it's very clearly understood that it is a member state driven process, with WHO acting only as a small secretariat for the negotiation and hopefully eventual adoption of a some sort of international accord on pandemic preparedness and response. And obviously this is the upshot of what we have learned from and suffered through as a result of COVID, and we don't want to repeat this again. And the second set of public hearings is happening at the end of September. And in the run-up to the second set of public hearings, we are hoping to work with as many partners as possible, providing partners with positive messages around the treaty process, around the benefits of it, that you might choose to use or not in your social media platforms, because very much linked to what has happened with Pangar, we see a lot of misinformation which feeds anger, resentment, conspiracy theories about governments wanting, or WHO wanting to take over the world, the resentment of public health authorities imposing lockdowns, mask mandates, social distancing, etc. So just to let you know, please, that if you are interested, we would love to work with you. We want to start a social media campaign around about the 5th of September, if we can get all our messages finalized by then, because starting the 9th to the 13th of September, in that 4-day window, we are, or the Secretariat is accepting video submissions for the public hearings. So we want to give that as much, how do you say, profile as possible. Yeah. And obviously, we would hope that we would get all sorts of supportive, positive submissions
Yeah.
from you all.
Yeah.
So that's my piece for the moment. Thank you, David.
Gregory, you are such a lovely guy to work with. Gregory is right in the heart of the communications team at WHO. He speaks English fluently, but he's German. And one of the things I'm super tempted to ask him, perhaps for our next open online briefing, if he feels like it, is just to explain to us the quite significant difference between the public statements coming, for example, from the German health minister and the public statements coming from the UK health secretary. In Germany, they're conscious that they're going to have some upsurges, right, Gregory, in the coming months. And as I understand it, the health minister is quite prepared to level with people that this is an issue they need to be prepared for. Am I right, or am I just barking up the wrong tree?
No, I think it's interesting. A week or so ago, I was having a sort of similar discussion with someone or on the same lines about how, let's say, the body politic in Germany is quite a bit different from that in the UK. And that, or in let's say other countries where there is, how would you call it? It's much, much less adversarial in Germany. And you don't get these swings. And you also then consequently get a very strong body of, let's say, sensible people in the middle. And I think that helps a great deal. And there is a much greater idea of I think, let's say, collective responsibility. So yes, I would love to talk about it more the next time.
Thank you very much indeed. I'm just checking with Gregory how he wants people to get in touch with him. He could put something in the chat, and also any indication of how you want to protect yourself against anything that might prove to be difficult to cope with. Gawaha, you wrote a lovely message in the chat. Thank you for that. In my experience, there's just one thing I've learned about communication, and that is to be as honest as you can be and never ever to get bored of your message. I sometimes think it's better just to keep saying the same message again and again. And you might feel bored of it, but you can't be sure that your listeners will feel bored of it. In some ways, I hear from people who invite me to come onto their programs quite often, they say, we like having you because you're consistent and we know the sort of thing you're going to say. And so, Gregory, it might be that at this stage, at least, having a consistency and a regularity and a rhythm mightn't be a bad idea. And I mean, hats off to Dr. Tedros, because he's very consistent in what he's saying.
If I could add one point before we go on, I think one of the earliest tenets which we developed at WHO in terms of what was then called outbreak communications was that because public health specialists deal with science, which comes from the head, which is cerebral, and the people that we are trying to communicate so often react to or think with their heart and get very emotional. When it's head versus heart, if it's one-on-one, the heart wins. So in order to overcome that disadvantage, it's exactly what David says. You have to continue to repeat and repeat and repeat. And that's what we did certainly in previous events. And I think also that certainly the consistency is extremely important, as is a multiplicity of voices. And just as an example, I think, that unfortunately, when you see something that happens that perhaps wasn't exactly right at the scientifically is revealed later, but you thought it was right at the time scientifically, an organization might never recover from that, which makes communications even more difficult.
So that whole business of how you change direction is so important, and we should talk about it carefully. Let me invite Gawahar, Marianne, Claire Taylor, and Florence Egal to speak in succession. I'll try not to come in between. So let's go to Gawahar first.
Greetings, David. Thank you.
Great.
Thank you again for a great session so far, and wonderful to see a number of new speakers as well and new people on board. And let me just add to my comment. I mean, when I worked with you on avian flu, I had never met a communicator like you, and I was well into 20 plus years at the UN at the time, or close to 20 years, I should say. It wasn't over. And the way you communicated to the private sector, to students, to government, I mean, it's just extraordinary. You really made your mark on the subject, as you continue to do now. Well, in my little life, I'm in Montreal. I only went to Europe for a short bit in May. It's been an interesting summer because everybody is out and about, but certainly we did have a huge surge. I've lost count. Is it the 6th or the 7th or whatever it was, but it was massive. Everybody got sick with COVID, me included. I now live with my 92-year-old mother. She didn't test positive, but she had some strange symptoms, not similar to the standard symptoms, and fell. But anyway, she's fine now, alhamdulillah. But it struck young and old, and most people were fine. But there is concern, as Claire mentioned, in our health system. I mean, all the weaknesses have now come out and been very sadly impacting some people with different health issues, not just COVID. I mean, there's less concern, there has been over the summer less concern about COVID because most people don't report their positive results, nor do they go to hospital for COVID. But those who have to go in for other things, it's a great concern in most provinces across the country. Ontario's having issues. We don't have enough nurses. We don't have enough doctors. It's pretty concerning. The other thing is the messaging. I've noticed recently in the news, say a month ago, they started to announce that not enough people had gone for their 3rd dose. We need more people. So people started to go for their 3rd dose and their 4th dose because they saw how many were infected around them.
Yeah.
Then this week, they spoke about the new vaccine. The people who recently got vaccinated, they said, "Oh, so the new one is going to be better. Why did we take the old one?" So it's back to the messaging issue, David, that I know you've mentioned so many times, and I think we're struggling with it. It's also an election period for the province of Quebec, and certainly Ontario went through it a few weeks back, and so the officials just don't know what to do. And I'm toying with the idea. I'm very involved with my alma mater, McGill University, part of the alumni boards, and do various activities there. And I once the elections are over, the Quebec elections are over early October, I'm going to try and find a way, and I would love your support and other colleagues online on what I should propose to McGill. I mean, McGill is doing a lot on this issue, obviously, and they have a huge role in the community and across the country. It's one of our better universities. And I think we need to have academia work towards supporting the efforts of the public health community. We never heard from public health in the past, and how we can communicate better, allow for mistakes, because they're going to happen. This is, as you mentioned, is a disease that we don't have enough information about yet. We'll know all about it when it's done. So that's my concern. That's what's going through my mind these days.
Right.
Want to package something for them.
Brilliant. I'm trying not to comment in between. Okay, this is a new discipline for me. To Marianne Hasselgrave, please. Thank you, Gawahar.
Thank you very much, and it's nice to be back again and to see you, everyone, again. I just have some quick comments. The first one, David, you do tend to forget about the impact on women. It's the greater impact on women than men during the pandemic. And in that connection, we talk about long COVID. There's also the issue of the long impact on the lives of individuals that we have to take into account, which might be the cause of some of the anger that's around. Mind you, the country that I'm in now there's anger everywhere, and we may have yet another health minister by the time we next
Really?
meet.
Okay.
Well, it's on the cards. One of
Okay.
them one wouldn't want to think about, but fortunately doesn't want to do it.
Oh,
Just to say that
Yeah.
we need to, when you're talking about the crisis,
yeah.
we need to look at the linkages. Now,
Yeah.
when we talk about the 2030 agenda, we're always talking about the linkages
Yeah.
of one SDG with another. Now
Yeah.
we've got a situation, and this is one of my criticisms from the beginning, as far as the Secretary General's crisis group is concerned.
Yeah.
He picked 3 areas,
Yeah.
but he didn't add in other areas that are affecting it, one of which being climate change.
Yeah.
So there's positives and also negatives
Yeah.
as far as linkages are concerned that we should perhaps look at. I would just like to say before I go that
Yeah.
I've come back from Uganda, where I went to a very, very remote area. There they have no water to speak of, and they have to get dirty water out of a horrible puddle, should we say. But there's a little place where you go and wash your hands.
Yeah.
When you go into the government buildings, you put your mask on. You don't go in without your mask. They're still wearing masks all the time, not in the casual way that we might wear them if we happen to get on a bus. I think the North needs a little more humility. Thank you.
Thank you so much, Marianne. Just so much in there. I listened to every word. To Claire Taylor, please.
Hello, nice to
Hi.
meet you. Sorry, no camera. I just came on last minute. Claire Rayner thought it might be useful to update what I'm seeing in my new long COVID clinic. So I work in Scotland, and where we don't have long COVID clinics with medical staff in them. We have physiotherapists for rehabilitation, and I have background in general practice, but ME and POTS and all that sort of thing. So became increasingly concerned this year about the lack of available healthcare to people with long COVID. So I actually set up a private clinic in central Scotland, and I've been doing it for a few weeks, and I'm utterly shocked at the standard of healthcare in a first world country. I have patients who have not had basic testing, who are desaturating, who are being told it's normal, people with other things not being ruled out that I'm now finding that are separate from long COVID. And what I'm seeing with the recent long COVIDs, which, you know, people who have had a migraine, is that it's not any less severe. The actual long COVID illness is not so severe, is not any less severe. People
Really?
are still bedbound, you know, with heart rates sky high, desaturating down to, you know, 70 to 80% on air on any sort of excursion, haven't had any tests, have, you know, spoken to a doctor and maybe had some basic bloods, but no scans. You know, I'm literally running circles around myself trying to get these people sorted back into the NHS, where I think they should have the most basic of tests done. And we'd like to reiterate everything you've said, that, you know, try and prevent getting this. We have no idea who are the unlucky souls that get long COVID. We have no idea really what sequential infections do. And I think the microclot stuff that we're hearing a lot about at the moment, you know, why can't we change the rules in the UK so that we can get rapid trials? We need, you know, what we did with acute COVID was opened up, you know, rules so that we could do the trials. Then we found out dexamethasone cut deaths by a third, brilliant. But then it's all closed back up, and the people with long COVID are, you know, wandering about between different specialties or doctors, or not getting anything, feel like they've been completely loss of anchor from their life. Some of them are losing their houses. And I think the other point is that children, so we still don't have any sort of air filtering in schools. We have, again, no idea what effect sequential infections have on children, but if we know this is a virus affecting people's blood vessels, I think we have to be a little bit, careful about what that means for that generation that can't make that decision at the moment, that we're making that decision for them about whether it's safe for them to keep getting infection after infection. So I think there's lots of things where, we're talking about living with COVID. We're not prepared to live with COVID at all. We're not prepared. We continually downplay it as mild. And I think, moving forwards, which, we're going to have to move forwards because that's what the world's doing, is that we move forward with a plan. And I don't have the answers to how we sort out, opening up trials and getting better care for long COVID and protecting children. But I'm hoping somehow there's enough people that want it to happen that we can sort of change this part of the pandemic, because I think it's a really crucial part of the pandemic. Thank you.
Thank you. You are extraordinarily clear, if you don't mind me saying so. That's not meant to be patronizing. It's me hearing you, me understanding what lies between your words and under your words, and wanting to connect with you. Whereabouts are you calling from?
So I live in Crieff in Scotland.
Very nice. If it's easy, could you please just make sure that we know how to stay in touch with you?
Yes, will do.
And we will find a way.
Yeah, Claire can connect.
Really, really important to stay connected. Claire Taylor and Claire Rayner will help us. Everybody, what you just heard is stunningly important in my view, not to be underestimated at all. Going now to Florence Egal, please. Welcome.
Thank you very much, David. And thanks for organizing these meetings. I try and attend whenever I can, because it's a good way to keep up to date on what's going on. But I would rather, instead of talking of anger, I would talk of fear. You switch on the radio now and you hear the problem with food system, the problem with conflicts, the problem with the energy crisis, the problem with climate change, you name it. My concern at this stage is we have systems breaking down, and you talked about the health system breaking down, but it's not the only one breaking down. And I think what we are facing is, like everybody says, the perfect storm. And at local level, it is going to be a big mess. And it is at local level that I think it's easier to bring people around the same table. I work on territorial food systems. We never see anybody from health. So I think it's high time for all of us to get around the same table and see how we can help municipalities, in particular in small and intermediate cities. How can we help local governments to say, what is our problem? I love the comment before. The problem in that area of Uganda is access to water. And I think we need now, the danger now is that different sectors are going to fight for increasingly scarce resources. We all agree we need to have an integrated approach. None of us will have the money to coordinate an integrated approach from a single sector. So I think it's important to say we are in a really serious situation in many geographical areas. And I'm not talking countries, I'm talking specific areas, specific population groups. Which are the problems? How can we help? How can the public health community help deal with diseases, infectious diseases and other things, but how can that be done together with other people, and how can we together fight to have integrated approaches? Thank you.
Thank you very much indeed, Florence. Where are you at the moment, please?
I'm 100 kilometers south of Rome in a garden, as you can tell.
And you are French, and you've worked on territorial issues for most of your professional life, as far as I know. So just to everybody, here is somebody who is an expert in food systems and nutrition, who's appealing to people from the health sector to join integrated action at the local level, what in your language is territoire, and to do it together. Am I right, Florence?
Yes, and I have a master's in community health from the London School of Hygiene, as you may remember. So you were one of my first bosses in their very old days.
Thank you very much indeed. Yes, many of us have been working together for several decades, and it's lovely that we're able to still stay connected and working together as we go through the years. Everybody, thank you for this opportunity to connect. Thank you for the luxury of being able to reconnect at regular intervals. And I just want to now invite, first of all, Catherine and then Mihika to make some final remarks. Catherine, please. That was meant to be a brilliant segue. Mihika, please.
Hi, thanks, David, and thank you everyone for joining for the first episode of this season. I've had COVID this week, so I am quite tired, but it's really nice to sorry, let me just mute that. So it's just nice to have this as the to end the week. But thank you very much. Our next meeting will be on 9th September. So hope that everybody can join then. Thanks very much. Bye.
Now, I know you are sort of titrating your energy very carefully, but Mihika, if people want to be joining the LinkedIn group or anything like that, is there anything that they need to do?
I can normally it's okay, but I think someone was having problems with that, and we are working on it. So I've been messaging her separately as well. So,
okay.
But if anyone has a problem, do let me know, email me, and we can figure that out.
Thanks.
But usually you should be able to find it on LinkedIn.
Excellent. And I just put my email in the chat, and Mihika's is the same structure as mine. I'm now going to just unusually, I want just to, before we close, I want to thank Gawaha for joining, and Marianne, because she sent me some really interesting emails over the summer that I've thought a lot about. Gawaha, thank you. As you pointed out, we've worked together on pandemic preparedness and response for a long time. Claire Rayner, I've mentioned, and it doesn't lead me to do any more than just acknowledge what you do in your leadership. And thank you for bringing other Claire Taylor in. Loy Rago, thank you for just checking us out on the words. To Miriam Hirons, nice to be with you. And Gregory Hartle, who does fantastic work from the communications department with all of us envoys. We really love what you do. Denise, thank you for being with us. And Christina Liu, nice to see you.